So, good evening, respected doctors. I and all of you definitely agree with Dr. Ma'am that surgery is the treatment of choice for pancreatic neuroendocrine tumors because it is time tested, there is no doubt about it. But do all tumors, and irrespective of its size, do all tumors, all patients deserve the weighted of surgery? That is a concern. And for small tumors, especially in elderly and frail patients, post-operative fistula, what has been already agreed, is high in number, diabetes, long hospital stay. These all things, do they give importance to the patient, or does this outweigh surgery or not? So EUS has a precise role that it is an organ sparing technique. It does not burn the organ. It is an organ sparing technique by which you can treat small pancreatic neuroendocrine tumors, preserving the endocrine and exocrine function, and it has similar outcomes as with surgery, and most important is that it has very lower morbidity post surgery when compared to surgery, and more than that, it doesn't burn the bridge to surgery. If the tumor reoccurs, always you can go for surgery. So why this debate? Pancreatic neuroendocrine tumors are increasingly detected incidentally. Many are less than 2 centimeters and low grade. Traditional surgery is definitely curative but morbid. And EUS RFA offers organ sparing outpatient therapy with growing guideline support. So today I will present some data by which you all will agree my claim of placing EUS RFA in treatment of small pancreatic neuroendocrine tumors, not against surgery but alongside surgery. So let us begin with a case, a 72-year male, history of diabetes, coronary artery disease. He had refractory seizures, he was on anti-epileptics. He had seizure episode associated with hypoglycemia, insulin levels were high, CT was normal. We were fortunate that EUS could detect 18 by 18 mm lesion in body, and by EUS FNA, it was confirmed that this is an insulinoma. So now what are the treatment options? One is already discussed, enucleation or surgery, medical treatment or EUS RFA or percutaneous RFA. But let us go to the data that surgery is definitely effective but at a cost. A meta-analysis of 62 studies have shown that fistulas will occur post-surgery in 14 to 58% of patients, delayed gastric emptying up to 18% of patients, new onset diabetes in 5 to 42% of the patient, post-operative hemorrhage in 6%, and pooled in hospital mortality and hospital stay are going to be high. So now any patient who has coronary artery disease, frail patient, 72 years male, should we go for such morbid surgery, or we should have some other kind of therapy which may have a relapse rate but lower morbidity? So why EUS RFA? Because it is simple, feasible, easier, effective, it has less adverse events, and also I will show you the evidence. Now when I say it is simple, why it is simple? Because those gastroenterologists who have an endoscopic ultrasound in their premises, they just need these two more instruments. One is EUS RFA generator and the needle, which is almost similar to use as in what gastroenterologists do, FNAB. In the close proximity of stomach and duodenum to pancreas, each and every part of the pancreas can be easily assessed and an RFA can be performed. Now the simplicity will also reflect through this video. I think it is not running, but you can see that the pancreas is very close to the, can you run it? You can see the pancreas is very close to the stomach. We can see here the body of the pancreas, and we will see a small neuroendocrine lesion which appears to be hypoechoic in nature. It is approximately 1 centimeter. The technique of RFA is similar to what gastroenterologists do in FNAB. Puncture the lesion and start the EUS RFA generator and this clouding will appear, which will clear that you can see this clouding. This is of 15 to 20 seconds and the procedure is done. Very simple daycare procedure. So now, why I say it is feasible and it is easier? Because in Tier 2 and Tier 3 cities across our country, EUS is available. Even in Vellore, in our prestigious medical college, it is available. Gastroenterologists who can perform EUS FNA, they all can do such kind of procedures, and hence not much expertise is required. It is effective because data says this. Technical success is 100%, radiological and clinical response is around 96%, and more than 90%, which ma'am has also shown for insulinomas. And the durability is maintained for 12 to 24 months, and retreatment is possible, either with repeat RFA or with surgery. Recent study by Crino et al. Have shown that patients who were treated for insulinoma by EUS RFA, they had very much less adverse events, only 18% compared to 61% with surgery. Clinical efficacy was similar in both the modalities of treatment. Relapse rate was definitely high in EUS RFA, but when hospital stay and follow-up was confirmed, compared, it was significantly high for surgery. And see this study by Kira group. This is an Israel study in which they have studied 18 patients. They have treated insulinomas, variety of other PNET lesions throughout the pancreas, and see here the arrow. Each and every time the patient preference was non-surgical modality. Even the study by Impertor et al. Have shown that those tumors which are less than 18 mm, they are the best predictors for therapy by EUS RFA, and they have good clinical success as well as radiological success. Talking about the location, head and neck are the most favorable tumors for clinical success, but any tumor can be accessible. And the type of the lesion, obviously we treat functional tumors which are less than 20 mm, but now guidelines say that, earlier guidelines say that less than 20 mm should be not treated, only surveillance should be done. But my dear friends, there is a mental, physical as well as cost burden on the patient, and many patients may not agree for this surveillance. In such patients, rather than going for surgery, simple EUS RFA can get rid of all this burden. When we compare surgery versus RFA, the adverse events are almost 40% with surgery in form of pancreatic fistulas, while in case of EUS RFA, patient will have mild pancreatitis up to 7%, and that is also transient and self-limiting. Hospital stay will be 5 to 10 days in case of surgery, while outpatient, patient will have an outpatient procedure with RFA, and efficacy is similar in both the modalities of surgery. Let me take you to the perioperative journey also. In surgery, you need a preoperative workup, anesthesia clearance, operating room for 6 hours, ICU admissions for 1 or 2 days, hospital days, 7 days of admission, 7 to 10 days, risk of drains, fistula, diabetes. But RFA, just 30 to 60 minutes of procedure, discharge same day, minimal analgesia, return to work next day. So please don't get irritated by this freeing surgeons headlines. It is not like that. I respect my surgery colleagues, but I want my respected surgery colleagues to operate where it matters the most, where they can make a more bigger impact, focus on complex lesion, nodal disease, high-grade tumors, and leave these small tumors for us by using EUS RFA. So this will also help for better patient allocation and outcomes. RFA is not a bridge to it's a bridge to surgery, and it is not a barrier to surgery. Surgery will always remain gold standard, and surgery is intact as plan B. EUS, important is that it is an organ sparing, repeatable procedure. If recurrence occurs, surgery remains viable. So my aim is not to fight against surgery, but to have a justifiable position of EUS RFA in treating pancreatic neuroendocrine tumors. Let me also give a very childish examples that if you have flat tire, what do? You just make a puncture or replace a tire, but not the whole car, right? If you have a mobile phone and the screen is broken, you replace the glass, not discard the phone. If you have clock ply just snake it. Don't rebuild the entire home. So in this case, if there is a small neuroendocrine tumor, why to resect and go for such a big surgery? Just do EUS RFA, give a good follow-up, patient not responding, recurrence, go for surgery. So I'm not in favor in all cases of small pancreatic neuroendocrine tumors that go for EUS RFA. Where I won't do it, if the tumor is less than 2 mm close to the lesion is less than 2 mm close to the pancreatic duct, I will definitely give it to Dr. Nalini to go ahead with the surgery. If it is in periampullary area, I won't do RFA because there will be necrosis and there will be chances of fistula. Gastrinomas, high case of recurrence, very aggressive tumor, nodal metastasis, I won't touch it. And obviously, if I am counseling any patient for EUS RFA, but still if he prefers surgery, I will definitely ask him to go for surgery. So take home message is, surgery remains gold standard and will always remain gold standard for more than 2 centimeters high grade nodal disease. EUS RFA, let us reserve for small localized insulinomas because they achieve similar efficacy with far less morbidity. They preserve pancreatic function and surgical options are always preserved. Let us consider this as a surgical triage, sparing frail patients from big surgery while freeing surgeons for complex cases. This will also help to utilize hours of operative rooms for deserving cases. So the concept is that utilize the right tool for the right tumor in the right patient. Thank you.